Understanding corneal biomechanics and glaucoma risk. Glaucoma is an eye disease where damage to the optic nerve leads to vision loss. The main known risk factor has long been high intraocular pressure, IOP. However, newer research shows the biomechanical properties of the cornea, essentially how springy or deformable the cornea is, also influence glaucoma risk. Two key measures are corneal hysteresis, CH, and dynamic corneal response, DCR parameters. CH measures how well the cornea absorbs and dissipates energy. Think of it as corneal shock absorption. DCR parameters come from devices like the Corvis ST, which use a quick air puff and high-speed camera to record corneal deformation. These measures are now easier to get in the clinic thanks to instruments such as the Ocular Response Analyzer, ORA, and Corvis ST. Recent evidence suggests both CH and DCR can help predict glaucoma development and progression beyond IOP and corneal thickness, CCT. Measuring corneal hysteresis and corneal response. The ORA, introduced in 2005, uses an air puff and infrared light to estimate CH. It reports two values, CH and a related corneal resistance factor, CRF. The newer Corvis ST system uses a high-speed Scheimpflug camera, over 4,300 frames sec, to visualize the actual corneal movement during an air puff. It yields many dynamic response metrics, like deformation amplitude, inverse radius, stiffness beyond CH. Importantly, each device produces different parameters and they are not interchangeable. For example, one study found that the Corvis ST's biomechanically corrected IOP did not match the ORA's cornea-compensated IOP, IOPCC. The two methods showed weak agreement and should not be used interchangeably. In practical terms, CH from ORA and DCR metrics from Corvis reflect related but distinct corneal properties. Clinicians are beginning to incorporate these tests. One expert review even recommends checking corneal biomechanics at baseline in all glaucoma patients and suspects. This means measuring CH and possibly Corvis metrics as part of the initial exam. In summary, corneal biomechanics can now be measured clinically, and experts suggest doing so in glaucoma care. Biomechanics and glaucoma onset, evidence is growing that low CH predicts glaucoma development. In one large prospective study of glaucoma suspects, ocular hypertension, about 19% developed glaucoma over 4 years. Eyes that converted had significantly lower baseline CH. Specifically, each 1 mm Hz lower CH at baseline raised the hazard of developing glaucoma by about 20%. Multivariable hazard ratio 1.2, 95% CI 1.01 to 1.42. In that study, after controlling for age and other factors, neither baseline IOP nor corneal thickness, CT, was a significant predictor. Only CH was. In practical terms, a 10 mm Hg CH and an 8 mm dram CH would translate to roughly 1.2 squared and 1.44, 44%. Higher risk for the eye with 8 mm Hg. This suggests CH adds independent prognostic value. Someone with borderline pressures but very low CH may be at higher risk than predicted by IOP CCT alone. The American Academy of Ophthalmology similarly notes that lower CH is associated with faster progression in glaucoma patients, including those with normal tension glaucoma, IOP in normal range. Their review found that patients with normal tension glaucoma had lower CH than IOP-matched normals, indicating CH matters even when IOP is low. In other words, corneal biomechanics seem to affect the optic nerve's vulnerability to pressure. In sum, patients with higher CH tend to have slower or less glaucoma risk, whereas low CH consistently signals higher risk of onset and damage. Biomechanics and glaucoma progression. Corneal biomechanics also predict progression in established glaucoma. In a landmark prospective study, each 1 mm Hg lower CH predicted about 25% faster loss per year of the visual field index, VFI. Over several years, this difference compounds meaningfully. Importantly, CH explained a larger share of progression risk than CCT, about 17.4% of the variation in visual field change versus only 5.2% for CCT. This shows CH adds predictive power beyond thickness and pressure. Additionally, in that study, the effect of IOP on progression was stronger in eyes with low CH. Eyes with both high IOP and low CH had especially fast damage rates. In plain terms, imagine two glaucoma patients with the same pressures and corneal thickness. If one has low CH, softer cornea, and the other has high CH, stiffer cornea, the low CH patient is likely to worsen faster. Clinicians might see similar effects in visual field tests. Lower CH often correlates with faster field loss, even after accounting for IOP. For example, Medeiros et al. Reported that weaker CH was significantly associated with risk of faster progression, supporting the idea that the cornea's shock-absorbing ability helps protect the optic nerve. Incremental value over IOP and CCT. Importantly, many studies show CH provides added value beyond known risk factors. In both onset and progression analyses, CH remains significant even after adjusting for IOP and CCT. In the glaucoma suspect study, neither IOP nor CCT predicted conversion once CH was in the model. In the progression study, CH explained about 3 times more of the outcome variance than CCT. In practice, this means CH can refine risk estimates. For example, an ocular hypertensive patient with moderate pressure but very low CH would be reclassified as higher risk than one with the same pressure but higher CH. Clinicians should thus consider CH in addition to IOP and thickness. The combination gives a fuller picture. As one recent review concluded, measuring CH complements current structural and functional assessments when gauging risk. Subgroup findings. Evidence suggests the influence of CH holds across different patient groups. For instance, CH is lower in all major glaucoma types compared to normals, including primary open-angle, angle closure, and pseudoexfoliation glaucoma. This includes normal tension glaucoma. Even when pressures are similar, NTG eyes have lower CH than non-glaucoma eyes. In Susanna's cohort, no subgroup, age, gender, race, overrode the CH effect. African American race did not significantly alter CH's predictive power in her study. In Mendelian terms, CH appears a generalized risk marker. Even patients on different treatments show this pattern. One study found that treated and untreated glaucoma eyes both differed from normals in certain corneal stiffness metrics. Taken together, current data imply low CH is a red flag in virtually any glaucoma suspect or patient, regardless of ethnicity or glaucoma subtype. Device differences and measurement precision. Different instruments can yield somewhat different biomechanical numbers. The ORA provides CH and CRF, while the Corvis ST generates many indices, deformation amplitudes, stiffness parameters, etc. Because of this, parameters are not directly interchangeable between devices. For example, one study found that Corvis's BIOP and OROPC could not be used interchangeably. Their agreement was poor even in normal eyes. In short, an ORA-measured CH is not the same as any single Corvis parameter. When applying research findings, physicians should match the metric to the device used in the study. As for reliability, both devices have good test-retest performance in normal eyes. A repeatability study of the Corvis ST found most deformation-related parameters had coefficients of variation below 4%. That same work reported good precision, repeatability, and reproducibility for its measurements. Similarly, the ORA has shown high reliability for CH. One report found Cronbach's alpha 0.9, indicating excellent repeatability of CH in normal subjects. In practice, this means a patient's CH measurement is fairly consistent from one visit to the next under stable conditions. Of course, factors like variances in IOP and measurement technique can still introduce some fluctuation, but overall both CH and Corvis metrics are reasonably reproducible. Putting it all together, clinical risk algorithms. Given these findings, clinicians can refine their risk assessment by incorporating corneal biomechanics into decision-making. For example, in a glaucoma suspect or ocular hypertensive, one could add an adjustment for CH when deciding how aggressively to treat or follow up. A simple approach: calculate baseline risk using IOP, CCT, age, etc., then increase that risk estimate for low CH. The Susanna study implies roughly a 20% higher hazard per millimeter lower CH. So if two patients have the same age, IOP, and CCT, the one with a CH 5 millimeters lower would have about 1.25 cores 2.5 times the risk of glaucoma. Practically speaking, a patient on the fence for treatment might be treated early if CH is low, but monitored if CH is high. For progression in known glaucoma, a similar logic applies. Even if IOP is controlled, a low CH, e.g. in the lower 20% of values, signals faster loss. In such cases, clinicians might opt for a lower pressure target or consider earlier surgery. Conversely, a higher CH, stronger cornea, might mean the eye tolerates pressure better, allowing a more moderate approach. Although formal guidelines for CH-based algorithms are not yet established, one can adapt existing risk models like those from OHTS or AGS by inserting CH as an independent factor. In sum, if CH is low, especially well below average, prone to consider more aggressive management. If CH is high, standard risk thresholds may suffice. Visual field and imaging follow-up should also be more frequent for low CH eyes. In conclusion, the latest evidence, mid-2026, reinforces that corneal biomechanics are useful modifiers of glaucoma risk. They add predictive power on top of IOP and CCT. The consensus is shifting toward using CH and DCR in practice. Going forward, clinicians can integrate these factors into patient discussions and treatment plans, ultimately aiming to prevent vision loss by tailoring therapy to each eye's individual biomechanics. Tags: glaucoma risk factors, corneal hysteresis, corneal biomechanics, intraocular pressure, central corneal thickness, dynamic corneal response, Ocular Response Analyzer, Corvis ST, glaucoma progression, risk assessment. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.